Well, welcome everybody to our Paul S. Richards Memorial Lecture Series. It is my honor to introduce Dr. William Marras, Bill Marras. I first met Bill over 20 years ago, and at that time he was already an intimidating researcher with an established research career portfolio. The great thing about Bill is he's really easy to get to know and very personable. So I'm going to go through many of his accomplishments and then turn the time over to you to continue to educate him. But, he is a distinguished university professor at The Ohio State University and is the Honda Endowed Chair in Integrated Systems Engineering. But he also has joint appointments in the departments of orthopedic surgery, neurosurgery, and physical medicine and rehabilitation. And he also directs the Spine Research Institute, which is a leading institute on spine research. It has had funding from NIH, NIOT, DOD, Ohio Workers' Compensation System, as well as institutes. Bill has over 300 peer-reviewed journal articles, numerous book chapters, and he also authored the book, The Working Back of Systems View. In terms of leadership and service, Bill's done a lot. He's longstanding contributor on the National Research Council. He's had multiple terms as the chair or on the board of Human Systems Integration. He's the former editor-in-chief of the journal Human Factors and is the current deputy editor of the journal Spine, right? Okay. As well as the past president of Human Factors and Ergonomic Society. He's been featured on NPR, he's done TEDx talks, he's done a bunch of different things and really helped advance common knowledge about spine injury prevention, as well as done a lot of research. So without going into too much more detail, I'm just going to turn the time over to you. So let's put our
sounds like the sound's on, right? So we're good. All right. So thank you very much, Matt, and thank you, Matt and Kurt, for the invitation to come and visit. This has been a wonderful visit. I've enjoyed my time here and enjoyed touring the labs. Enjoyed dinner last night, so it's been fantastic. Also, thank you to all of you for sharing your lunch hour with me. I thought it was wise not to try and eat while I'm talking, so I'll do that a little later. Today, I'm going to talk about low back problems. And usually, when I talk to a big group, I usually start off by asking how many people have back problems, and usually 3/4 of the crowd raises their hand, but you guys are too young. So just remember this in 20 years and think about that question then. What I'd like to talk about today is really a couple different things. One, I'd like to introduce you to the Spine Research Institute at The Ohio State University, of which I direct. And I'm just going to give you a high-level overview of what we're all about and how we got started. And then I'd like to talk about this project I've been working on for the past 6 years, which is really about trying to develop phenotypes for low back pain. And I'll explain why that's important in a minute here. But I'm going to cover everything from developing the technology to measure it, to how you collect the data, all the way to how you go about finding prototypes or phenotypes, of which we're still working on this. So it's really a work in progress, but it's been a lot of fun. So we usually start out with disclosures. Here are my disclosures. You can see my research funding on the bottom there. Those are the people who currently support us. That's obviously changing with the feds right now, but we'll see what happens. And the top ones are just other places I get income and things like that, but I don't think there are any conflicts here with what I'm going to talk about today. So the Spine Research Institute was an outgrowth of my laboratory, which I started in the 80s, which was called the Biodynamics Laboratory. And it started in a room that was about the size of a restroom. It was very, very small. And we've grown over the years. And now in 2016, we graduated to a university level institute. We have the whole floor of a building. So you can see we had a lot of money to try and fix this place up, and it's turned out being just a fantastic facility. I think it was Scott was telling me today about his motion capture system. We got lots of motion capture systems. As a matter of fact, we have in the neighborhood of 125 cameras, believe it or not. So next to Disney or somebody like that, we're probably one of the larger motion capture systems you're going to see out there, and probably one of the larger ones you'll see for biomechanics. And the goal of the Institute is simply to understand how back disorders work. And here's our mission statement. You know, we do that in two ways. One is we conduct research to identify causal pathways. Because the dirty little secret is nobody really understands much about back problems. We know how to prevent them, but we really don't understand the causal mechanisms. And even with good ergonomics and things like that, some people still get them. And so we're trying to understand how that messy system we call the human works, which is not easy. And I'll explain more about that in a minute. And then given what we find there, we apply this information to try and develop technology that could help the prevention, evaluation, and treatment of people with back problems. And so, you know, I'm one of these people who believes it's great to do research and it's great to publish in journals and have your colleagues look at it, but we really got to get it in the hands of people who could use it. And so that's another one of our objectives. Let's have this, right? Okay, so here's our leadership group. So this is people who are directly paid from the Institute. And, you know, I'm the executive director. Greg Napick is associate director, and he's, you know, was one of my former graduate students. Kristen Weaver's an MD in anesthesiology. He's our clinical director. And then we have a good set of staff. And so we've got about 20 full-time people and then a handful of graduate students just in my group, and then graduate students from other groups too. We've got a lot of collaborators, which are shown here, and you can see I've divided these up into the different colleges that are really contributing to what we do. So we've got other collaborators in engineering. We do a lot of collaboration with medicine. We're a joint project with engineering and medicine, although we're being led on the engineering side. And then we have cancer engineering. OSU, Ohio State University, is a really large cancer medical center. It's like probably about the second largest one in the world, I think it is right now. And so they have a heavy emphasis on that. Why do we deal with back problems and cancer? Well, it turns out 40% of cancers that go untreated eventually go to the spine. And then they eat away at the vertebral bodies, they collapse them, and then the surgeons have to figure out how to put people back together so they're not in bed for the rest of their lives. And so that's how we get involved at that level, trying to help figure out how to fix them. We deal with bioinformatics. We have two bioinformatics teams. One is statistics, the other one is artificial intelligence and machine learning. They work independently in our institute. We have them tackle the same problems, but they don't talk to each other. And you know, and we do that on purpose because we want to see if they're going to come up with the same answers, because we're after understanding, not just black box of relationships. And then also we have a bunch of, you know, development support. We spend millions of dollars a year just hiring outside companies to work with us for our developments. And basically what we do is stitch all that stuff together at the end of the day. We also have a pretty big research portfolio. So on the left there, you see our state and federal sponsors. Matt already.
Oh, yeah, baby girl.
All right. So I'm also a ventriloquist. I forgot to tell you. So we have on the left here our state and federal funders. We also work a lot with industry. We've worked with hundreds of people over the years, hundreds of different companies. And right now our big one is Amazon. You could probably imagine the back problems they have with all in their fulfillment centers. And then we have a lot of external collaborators. So we're part of an NIH consortium called Backpack. And so that's part of HEAL, if you've ever heard of HEAL. HEAL stands for Help End Addiction Long Term. And so it's all about opioids. It's $1 billion consortium. And a subset of that is called Backpack, because it turns out back problems are one of the leading reasons people take opioids. And so the consortium bands together and tries to understand back problems, and we're lucky enough to be part of that. And all these universities you see here, many of them that we work with, are listed here, and all these people are using our technology to actually collect data. Also have a similar effort going on in the military. That second group on the bottom on the right is some of our military partners. So all in all, we have about 75 people using our technology around the country right now. And we get a lot of data back from them and try to understand what they like, what they don't like, and try to improve that. So a couple things that we brag about. Historically, some of the things we've done, there are two things that are probably noteworthy. Probably a lot of you are too young to remember when scanners looked like this. Anybody ever seen one of these? I know Kurt has. Yeah, okay. So this is the way scanners in grocery stores used to look. And notice the starburst pattern here. The cashiers used to have to take the product and do this. And as you can probably tell from me doing this motion, that causes a lot of friction in the carpal canal, which led to carpal tunnel syndrome. So we took some measurements of this. We were funded by a couple organizations to trying to understand what's happening here. So as you see the instrumentation on the person, we use that to understand both the model about the friction in the carpal canal. And then we reported back to these organizations and said, okay, we think we know what's going on. When they're trying to follow these patterns, people are co-contracting all the muscles in their forearm because all the muscles that control the finger are down here, right? And so we said, that's, what's causing the problem. That's why we have all this, because people are trying to hit those targets. And so they came back to us and said, okay, what do we do about it? Well, we came up with the concept of the bioptic scanner, which is this guy here. And first we said, well, you need something where you don't have to follow these lines. You can play with the prisms and the mirrors and get this thing to read all the 360 degrees around. And they said, we can't do that. And we said, well, what would help? And we said, well, if you could get us 270 or so, that'd be great. And so that's what this does. There's still only one scanner here, but the prisms here that curve the light around. And so this is what's in, well, it says here 85% of all grocery stores around the world. It's probably more like 95% now. And that was our idea. And we're very, very proud of this. And the companies that funded us rewarded us very handsomely for that in terms of building us a lab and a computer center and all that stuff. The other thing we demonstrate the value of prevention is, so this is some work we've done with Honda, as Matt mentioned at the Honda Endowed chair. And part of that was due to some work we had done with them where they came to us and said, we got all kinds of musculoskeletal problems in our manufacturing plants around the continent. Could you help us? And so we did a bunch of studies. We tackled them from the most severe problems, let's tackle them the worst problems, second worst, third worst. And basically, these are all ergonomic type of solutions. And then Forbes magazine did an article on the relationship between us and Honda. And this is our one of our labs here. This is how we wire people up. And they said that we've helped cut their injury risk by 70% in the past 5 years. And I understand that was an understatement. People at Honda told me it's more like 90%. So ergonomics does work if you use it, if you could get people to employ it. Okay, enough of that. Let's talk about the kind of work we do. And it really is in 3 buckets here. So like I said, what we'd like to do is understand the causal pathways for low back disorders. And the way we do that is by collecting very precise data and then building personalized models of people. And so here you can see we've got somebody wired up so we can pick up what the muscle activities are. We're looking at how they move in space. We've taken CTs and MRIs of people, and we could use this information in these first 2 panels to build very realistic models of people. This is a personalized model of a person with that person's muscle activities, which you see are the red arrows here. That represents the magnitude of their muscle activities. It has their vertebrae in there, their discs in there, and it's dynamic. So it's almost like a dynamic MRI, which doesn't exist today. And so we use that to understand what happens and try and prevent injuries. So we use these models for prevention, for ergonomic purposes, and a couple of them are shown here that we've used over the years, as well as for understanding how to quantify the extent of low back disorders and trying to help the clinicians assess people. And today, I'm going to talk only about this, and only about the clinical applications. So let's talk about backs. So back problems are the leading cause of disability in the world. Every country in the world, not just the US. Any given day, 5 to 6% of the population will have a back injury. Any given year, 20 to 25% of the population will have a back injury. Over the course of a lifetime, 80% of people will have a back injury. So you're almost guaranteed to have one sooner or later. And it gets very, very expensive. It's the number one cause of disability. Our healthcare expenditures are actually number one. They're more expensive than anything else we spend in the medical domain. And we have, number two reason that opioids are prescribed, and it's just getting more and more expensive every year. So there's been some articles out there that have shown the cost and how it's changed over the past 20 years. It's got more and more expensive, 300% more expensive, but the cure rates are no better than what they were 20 years ago. Exactly the same. Prognosis. One of the things people don't realize is 85% of the time, they're, clinicians don't know what's wrong with people. These are unknown origin of the back problems. So nondescript types of back problems. If you get an MRI, 85% of the time, it'll tell you nothing. If you look at people who don't have back pain, take MRIs to them, 85% of the time, it looks like those people have back pain too. Looks like the people with back pain. So what does the static image really tell you? And when you think about it, it makes sense because you're laying on a table, they put you in an MRI machine, and you're not moving. And nobody hurts when they're not moving. It's usually when you're bending and twisting and turning that you're activating those receptors and people are starting to feel pain. It's really hard to get that information off an MRI unless you have a broken vertebrae or a ruptured disc or something very serious. And a lot of the people who have back pain, 28% of people who have back pain eventually are considered chronic. Chronic low back pain means that you've had back pain for more than 3 months, and the average duration is about 7.5 years. So these are the people we focus on, trying to understand what happened to these people. Who they don't understand what the diagnosis is, they have pain, they've tried everything, and they can't help them. That's what we're trying to understand. A little bit about treatment. Okay, treatment's kind of amazing, as you can see over here. And, it's really, unfortunately, trial and error. One of the things that the surgeons tell me is it's all about the right treatment at the right time for the right person. If they can figure that out, then they've got a really good chance of getting that person better. But how do we do that? Trial and error. First you start with PT, then you might start with injections, then you might do RFA, you just go on and on and on and on. And we know that the longer you go on, the more you're going to establish these pain patterns in your brain that are going to be really, really difficult to break. And so that's why right time is so important. So that's one of the things we're trying to do is figure out how to get this information to the clinician at the right time to help them, before they go through all this trial and error and all that cost. So one of the problems with back problems is it's hard to understand what's going on. As we said, most of the time we don't know what the problem is. And if you compare that to the other, big two cost generators for health, heart disease, diabetes, with heart disease, we have lipid profiles. We have, HDL, LDL, when those things get out of balance and what happens if they do, the doctor knows immediately you need a, statin or something like that. So they can do something. They know how much is too much. Same thing for diabetes. We know A1C. We know what's normal. We know what's pre-diabetes. We know it's diabetes. If you get into the diabetic range, what do? Well, you give people insulin, right? As we already talked about with low back pain, We don't have those precise indicators. We have pretty pictures. They're great pictures. And if you got a tumor or something like that, you're really glad you have them. But if it's your normal back pain stuff, it's really hard to tell how much is too much. Because like I said before, a lot of times back problems, do not line up with what you see on an image. Same percentage of the population will look like they have back problem, whether they got back pain or not. That's problematic. So what are we left with? Smiling faces. Okay, so we have, how do you feel about your back pain today? Pick a face and tell us where you are today. And in 3 months, when you come back to see the doc, they say, okay, pick a face today. What does that even mean? It's very, and what I'm saying is very, very subjective. Okay, and unfortunately, that's all we have to work with, traditionally. So what we've been on is a mission with our NIH funding as well as our Department of Defense funding to develop phenotypes of people with low back pain, so you can at least categorize them and figure out where they are. Given your biometrics and things like that, what kind of back pain do you really have, and what is your probability of getting better, and what's probably wrong with you? That's what we're trying to figure out. How do you do that? That's why we're trying to phenotype. Because most of the time it's non-specific back pain. That's what the typical diagnosis is. Like I said, we don't know what that means. But here's what I'm going to talk about. I'm going to talk about our development of our wearable sensor platform, the development of our biomarkers in our modeling, looking at how you develop these phenotypes of clusters, show you how we can predict improvement, show you how we can help predict diagnostics. And then a big area right now is pain stratification. Now we know there's different types of pain. There's neuropathic pain, and there's nociceptive pain, and there's neuroplastic pain, things like that. I'm going to try to show you what we're doing there to try and differentiate these, because these are a good clue for the physician to figure out what direction to go with treatment. So one of the things that makes back pain very, very difficult to understand, and why most of it is non-specific, is because people are very messy. And we said that earlier, but they are truly messy. So not only do they have, everybody's got different biomechanics for all kinds of reasons, but everybody's got different biology, everybody's got different psychological profiles, anxiety, depression, personality beliefs, different socioeconomic relationships, education matter, the support from your significant other, social support from your boss, all that stuff mixes together to define what your back pain is all about. And we've known this for years. This is back to the work of Gordon Waddell back in the 90s. He proposed this, and it's absolutely true. Everybody looks at this stuff, but nobody knows how to put it together. So, what are we doing? Well, we're trying to put it together with some biomechanics. So one of the things that we've done over the years is we developed the world's first wearable sensor for the spine. Back in, I actually had a patent on this in the 90s. And we've done tons of articles about that. But the bottom line is, if you got back pain, you're going to move differently from people who don't have back pain. A lot of physicians have told me, I asked them how they evaluate it. We interview tons of physicians, and I've asked them, how do you tell how bad somebody's back pain is? And some of the really good ones tell me, well, I just watch how they get up out of their chair and walk into the office. And if they're very tentative about things, I know things are pretty bad. If they pop up and walk through easily, I know maybe it's not that bad. And so that sort of gave us the idea, maybe we should measure this. And that's what we're doing. And so we've developed, here's that 90s device we developed. It's looks pretty crude, but remember, this was the 90s. This is before we had IMUs and things like that. So we basically built an exoskeleton of the spine, not a lifting exoskeleton, but a sort of a second spine for the person that mimics what you do as you move around. And we measured motions and measured not only range of motion, but velocity and acceleration. And that became some of our metrics. We've got dozens of papers that talk about, you can tell the difference between people who have got pain, don't have pain, how bad it is, things like that. And then we've spent the past couple of years trying to improve this. And now we've got this isn't even our latest version, but we have an even more advanced version here, which is based on IMUs that we've custom put together. And we use these in a, we use this in about a 6 to 10 minute test. So this is a clinical test. So this is not kind of an IMU you put on, you go to work and you come back at night, take it off, see what the person did. This is something you use in a clinic. And this is what we're doing at those 75 providers around the country. So everybody, gets a kit, and the kit, to maintain the data integrity, we've got to make it so it's really hard to mess up. So we spent a lot of time thinking about the human factors of the presentation. You can see some of our software there. All this stuff's built into the software. Step-by-step walkthrough instructions, video instructions for both the provider as well as the patient. We got error detection, so you can see they're telling you how to twist and turn. You get a check if you're doing it right. You get an X if you're doing it wrong. It gives you all kinds of hints of what to do. It's all cloud enabled, so this stuff automatically goes to the cloud. It's secure. Like I said, it's quick and you get immediate results. So we're very proud of this. We spent a couple of years just trying to go through this, and there are two conditions that we have people do. Basically you move in all three, planes of the body. We have people do that once slow, so you can get the full range of motion, and then they do it as fast as they can in the second. And that's the test. They're very quick. Now, a lot of people use IMUs, but very few people realize the drift problem with IMUs. If you take an IMU and you set it on a table, move it around, come back, and look at it again in the same place, it'll go back to the same coordinates. But take a look at the IMU as you move it around in space. Use your motion captures to look at what happens as you move around, and you're going to get this. Okay, so there's a green line, which is there's a black line, which is hidden by the green line, which is what we get with the mocap system. There's the green line, which is our drift direction that we've built into this system. And then there's the red, which is without correcting the drift. And you can see you get drastically different results. Drift is significant. So make sure if you're going to use this for assessing what's going on in the workplace or the clinic, that you don't fool yourself into thinking you get accurate data. Because we've yet to see one that doesn't drift, even though, like I said, statically it may calibrate well, dynamically it doesn't. And what we pay attention to is not only the position, but velocity and acceleration. This shows, we can get between 98 and 99.5% accuracy doing this, which is good enough for us. So we built a model of this, and I'll talk about the model creation in a minute, but our accuracy is about 80%. Here's the sensitivity, specificity, and the MCID is about 8 to 9%. So what are we measuring here? We're looking if we could tell the difference between people with back pain and without back pain, just by looking at their motions. And you can see you can do it without about 80% accuracy. And this will make a little more sense why in a minute here. We've done tests on reliability, repeatability, and we get ICCs of in the good to excellent range. So you have to make sure that what you put in your model is trustworthy, and that's how you do it. And we use primarily the velocities and accelerations, which actually turn out to be much better than the range of motion for these models. So our biomarker is sort of a cocktail of all these different velocities, accelerations, and range of motion. We call P of N, or probability of motion. So given this test, we could tell you, given your age, what the probability is that you look like a normal person versus a person with back problems. We compare our two groups. And here's a study where we developed that. And let's start with, we'll look at, go in order here. So we look at motion features. So by features, I mean we look at motion peaks, averages, things like that, as you're performing these tasks. We also look at time series, which are, what if you look at the whole signal as opposed to just the peak and the average, things like that. We look at demographics, clinical characteristics, and they're shown here, age, BMI, smoking, things like that. Look at pain-related domains, pain intensity, pain interference. There's something called promise, which is an NIH developed patient-reported outcome metric. And so that's what we use for this. It's sort of like, if you've ever heard of the Western scale, it's like an updated version of the Western scale that's sanctioned by the NIH. We look at the psychological domain, depression, anxiety, fear avoidance. There's a lot of people believe that if you're not moving well, it may be because you're just afraid to move well, right? And so we measure that. We looked at, and then we looked at both, people with chronic low back pain as well as people who've never had back pain. There's symptomatic controls. And here's our schedule. So what we do is we look at people at baseline, have them go through this 6 to 10-minute test I told you about in the clinic. Then we look at their data, then we wait 3 months, see how they did. And actually it goes way beyond this. We actually monitor people for up to 5 years. But I'm just going to talk about the follow-up, which is 3 months, because we're still collecting data on this. So here's the planes of the body. And like I said before, we look at people moving, slow, trying to get full range of motion as well as fast. And here's our database. According to, as of January of 25, we had 1,041 people with back pain, 765 controls. We got about 400 or 500 more now, but the results haven't changed. And here's the people that in our different age categories. And you want as many people in the control, which is in the red, as the back pain patients. You got to balance these the best you can, or else you're going to make errors in your predictions. So that just shows how we've done that. When we run the model, here's what we get. So here's our motion index in the vertical axis. Here are the controls on the left, the low back patients on the right. You see both male and female. And what do you see? Good separation between them. So one standard deviation below the mean of the controls is about where the mean is for the low back population. So it makes a difference. And this is very significant. Does it relate to pain? We've given people pain severity metrics, asked them to tell us on, what their pain level is. So here's our control group again, and you can see as the pain gets more severe, the motion goes down. So it goes in the right direction because what we'd expect it to be. So let's look at some of these features. So now we get into the clustering, developing of the phenotypes. Is that clock correct? I think it is. Okay. So here's a clustering with our two principal techniques, and you can see it falls nicely into 3 groups. So we have people who have poor motion in the blue here, people with very good motion in the green, and people with sort of moderate motion function disability in the middle. A lot of these people look like the controls. None of these people do, and none of those people do. Okay, and so that's what we're dealing with. So we have 3 categories. So that's our first crack at a phenotype, and this is sort of the loading plot. So what goes into component 1 versus component 2. So we see all the velocities and accelerations are over here. The range of motion is up here. So they load differently. Range of motion tells you something a little bit differently from velocity and acceleration. But we know motion in component 1 explains about 65.5% of the variability, where motion in component 2 explains about 12.5%. And one of the things we know is most of the things that are along component 1 come from asymmetric motions, moving to the sides, and load heavily on the dynamic stuff, velocity and acceleration. In component 2, that's more of the sagittal plane stuff. Bend down, touch your toes. But look at the difference in the variance sets explained there. So you have to look at people moving asymmetrically. How do these motions compare to other comorbidities? So I don't know if age is a comorbidity, but it's in here. So the first one is, if you look at our poor functioning cluster, those people are older. Just compare the person last primarily because it's all kind of linear. So they are older than the high functioning group. BMI is higher in the poor functioning group. Fewer of them are employed. Joint pain. So this is widespread joint pain. So all over your body. So you can see here, 48% of those widespread pain for the poor functioning with only 32 in the high functioning. Same thing with high blood pressure, same thing with diabetes. So not only back pain, but you're carrying around a lot of these other comorbidities. And this is sort of the beginning of the cluster or of the phenotypes. So this is trying to see how sensitive our motion indicator is to whether people got better or worse over 3 months. And so here's our pain scale down here in the bottom. It goes from a 7 to a 1. 1 means they're very much improved, 7 very much worse. The purple or bluish columns show the baseline the first time we measured them. The orange show the second time or 3 months later. So when people were worse, so that's this, you could see they had corresponding motion deficits that occurred. When they got better, especially this one here, very much improved, you can see it's reversed. So motion is responsive over time. It's not just this one cross-sectional look that you got at it. How do they get better over time, and does it correlate to the clusters? Well, the answer is yes. So here's, again, our 3 clusters: poor functioning, high functioning, moderate. And you can see the green shows the people who had a positive response. They got better. Red shows people got worse. So in this group, the poor functioning, only 46% of them got better, 25% of them got worse. Compare that to the high functioning, it's kind of reversed. 59% of them got better and only 14% of them got worse. And what we're trying to figure out is who's who in this group. Okay? Can you pick out the individual people? Can we predict things with time series? So as we said before, with motion only, you get about an 80% accuracy. But now if we put these things together, not only use the motion, but what if we put these promise measures, these PROs together with it, then our predictions jump up to in the 90%. So all the things that people have traditionally been using, like patient-reported outcome, like fatigue, depression, anxiety, sleep, those make a difference. Okay, they help. Those alone are not going to do a great job, but if you mix them with motion, then you got something. And that's what we've been been following that trail. And so here's a phenotype which gets even deeper. Right? Gets even deeper. Yeah, we're trying to zero in on different subclusters now to see if we can figure out, who's got specific disabilities that we can believe, and what's their chances of getting better. So you can see we got very well-defined clusters here. Notice there aren't as many people here because, as I said before, a lot of times you don't know what's wrong with people. And so out of our 1,200 people in our database, we only took the people where we've got pretty good diagnoses that we trust. Okay? And so the people up in this cluster, the people who look like they're normal, their motion and their PROs look just like the controls, and their chances of improvement are very, very good, 85%. Even though complaining in back pain, we could identify them as somebody who will get better no matter what you do. Okay. This next subcluster here is they have low back pain qualities that only appear in the fast motions. So as you're moving, like I said, we check slow motions and fast. If they only have a deficit in the fast motions, then these people are going to have a higher rate of stenosis, and their chances of improvement are 78%. We got another cluster here, which is a little bit different from that one, and they're going to show deficit in fast motions plus slow axial twisting motions, and their chances for getting better are only 53%. So, our contention is the clinician could use that information to know how aggressive to be in their treatment. Okay. There are a couple more clusters over here. These guys have a high rate of degenerative disc disease, and you can see it's the slow lateral trials moving from side to side that they showed problems with, and their chances of improvement were 78%. And finally, we have people down here. These people have a higher rate of spondylolisthesis, and in the slow lateral and fast trials, in other words, both types of trials, they were poor in their execution of the motion, and their chances of getting better are only 47%. So these are the kinds of things we can provide that kind of help. Hopefully, if you could phenotype people, this is what phenotyping is all about. If you could provide this information to the clinician, then they could act on it. They could combine that with their clinical knowledge and know what to do. We also could do other things with this. So diagnoses, typically the first division when you're looking at people with back pain is it muscular or is it structural? Is it a pulled muscle or is it a disc that's bulging? Or is it a vertebral that's got a crack in it or something like that? So we can do that with an accuracy of about 69%. Got a couple of these. PGIC is global impression of change. In other words, are you getting better over the 3 months? And we could predict those people will get better with about 75% accuracy. And finally, we have reoccurrence. When you tell who's going to get re-injured, and we can do that with an accuracy of about 62%. And this is all with looking at that time series information in our models. So why is this important? Well, one of the things all the physicians tell us is, I want all this stuff in one panel right in front of me, so I can tell what's going on. Because these guys are busy. They get, especially at Ohio State, they may have 5 minutes to be with the patient. And they can't look up past history and things like that. So we work with some of our designers to put together panels like these. And these are 3 real patients. And so what we have is their overall motion. This is their probability that things what's the quality of their back pain? Is it not too bad or is it really bad? So the red is really bad. This is, they look like the normal people, and these are somewhere in between. Here's the specifics of the motion. Here's their PROMIS scores, and we color code these red, yellow, and green. We also have a body map that tells, where does it hurt? And we also have, their pain intensity. And the reason people go to the physician is because of the pain intensity. So notice all 3 of these subjects have the same pain intensity, 6 out of 10. But look at their motions and look at their body maps and look at their, PROs. They're all very, very different mixtures. And so, for example, this person moves very, very well, but they got widespread pain, right? All over their body. Okay. And if you look at their psychological profile here, they get an anxiety and depression, also fatigue. And, the only thing that looks good is their social participation. Compare that to this guy on the right here, and they have very specific, this is called axial pain, when it's in one specific part of the body, it's all over the place there. And you can see they get a very different profile. Their motion is deficient. It's got problems, and you can tell exactly what plane of the body it's in. You can also look here, their profiles are different. This person does not have depression. It's moderate anxiety. And so you got a different formula for this guy versus that guy. That's the beginning of the phenotype we're talking about. So finally, let's talk about pain stratification. This is where it gets really fun. So pain stratification, as I said before at the beginning of the talk, pain assessments are changing, especially in the anesthesiology world. So there's nociceptive pain, there's neuropathic pain, and there's mixed pain. So neuropathic pain means you're insulting a nerve. If you have a disc problem, typically that pushes against the nerve root that goes down the legs. That's why you hear people who've got, leg problems and they got back problems, right? Nociceptive pain is insult to a tissue that's not a nerve. So a muscle problem, or it could be, a bone bruise or whatever, but it's different. And then you've got this other category called mixed, which is a little bit of both. And so we have looked at the pain stratification using this metric called pain detect. This is a questionnaire you fill out. We went through our data and looked at people who classified as nociceptive, mixed, or neuropathic. We looked at features such as their motions, their demographics, all the stuff we looked at before. And then we used artificial intelligence and machine learning to see if we cluster these people. If you don't use motion, here's what our clusters are. And I don't know if you can see clusters in there, but I can. If you add motion, it looks like this, which we think is really, really cool. Okay, and so you can see they break into the nociceptive group, neuropathic group, and the mixed group in a very organized fashion. And then we have subclusters between these, and we're currently trying to understand what these are and trying to build these into a metric. So let's just look at two of these subclusters. So the first one here is nociceptive 1 right here. And so those are people with, they move pretty well. They have mild pain interference, low psychosocial distress, low pain catastrophizing, low kinesiophobia. Over there on the right screen, you see the gray dots there. These are people who did poorly. So those are neuropathic. Again, this is people who've got the nerve impingement problems. You can see they're the opposite of these guys. And we're coming up with these kind of descriptors for every one of these. As a matter of fact, at still a very high level, it looks something like this. And I've just highlighted those two groups that I just talked about. So here's nociceptive 1. They move very well. And down here, these are people complaining less about things like, depression, anxiety. Compare that to people over here who are highly impaired. That's neuropathic. And they are complaining a lot about all these things, sleep, fatigue, psychosocial, and their emotions are also a little worse, much worse than these guys. And you can see different patterns for all these guys. Yeah, this is a neuropathic group, as is this one, but they classify differently. And so we're looking at what's the difference between this group and this group. These guys have higher BMIs. And so BMI is something we think, we could possibly change that, especially these days. And so we're going through each one of these categories now to see if we can make sense out of it. So what are we doing now with this data? Well, we're interviewing a lot of physicians and asking them, okay, we've got the beginning of these phenotypes. Help us understand how we can help you with this information. And so, as I said before, all of them are telling us, I want something real easy to see. I want something I could turn the screen of my computer and show the patient. So they need validation for what's going on. And so the thing we're adding here now is predictions. So we're going through the data, looking at people, how they're turning out, trying to find out what their specific problems are and coming up with probabilities that, it's non-specific back pain, spondylolisthesis, stenosis. Give them a probability of all that, and then give them a probability that what they do is going to help. And given that treatment. So again, this is what personalized medicine is all about, is getting to the point where for that particular person, here's what gives you the best chances, as opposed to treating everybody as trial and error. Let's talk about the problems with that. Now, a couple examples of where we've used this. We've used this on pilots in the military, and this black dot here, that's where people classify as normal. So these blue columns are F-35 pilots, fighter pilots. The green ones are F-15 pilots, and the last two here are combat pilots. And we looked at where people were when they, when we tested them at some military bases. And you can see a lot of these guys are hurting. And what you get with pilots is very different from what you get with a lot of industrial workers. Because there are some industrial workers who are going to over-complain and maybe exacerbate the problems. I don't think there are a lot of them, but there's some. But the pilots are exactly the other way. So, the military spends $40 million training a F-35 pilot, and they don't want to be corrupted. This is what they train for. So they're not going to tell you if they get a problem. And they actually told us, if you publish my name, I'm not in your study. So anyways, this is one potential application where in their annual physicals, you can see what they're doing, see how they're doing, and get them help before they become corrupted, because they're afraid to say anything. We also looked at people over time. So this is that same F-35 group. So this is what they tested at baseline. And then 8 weeks after training, 16 to 24 weeks after training, we had a 32% drop. So the training is beating these guys. And and then if you look at the training, it's very, very rigorous, and you want it to be, but you also need to do it in an intelligent manner. And then they let up after this 16 to 24 week. And from what they tell us, the training gets much easier in the last, 8 weeks of the course. And look what they got there. So, in conclusion, I'm sure that's what everybody's been waiting for. Motion is important. When we mix motion with these patient-reported outcomes, you got something that could be the beginning of a phenotype, and that's what we're trying to zero in on now, and it's looking very promising. It aligns with a lot of the theoretical premise that spine motion signals offer an indirect window to what's going on inside the body. I've been studying motion now for 40 years, and I could go on and on about what happens inside the body with motion compared to statics, and it's night and day. We cluster people, and these are sensitive indicators of pain as well as other PROs. There's some longitudinal potential here. We can predict what's happening in the future. We can predict just from a baseline, we can predict where people are going to have improvement, where they're going to have recurrence, and whether it's muscular or structural. And like we said before, we could actually starting to tell the type of pain they have, which is what a lot of clinicians are asking us for. So I'd like to acknowledge the team, and you can see a lot of people involved in this project. And I get a fantastic team. These guys are all phenomenal, and they're very dedicated. A lot of them are my former students, especially full-time people, and they're all just super. There's our funding through the NIH as well as the Department of Defense. And I'd like to leave you with this. So this is Lord Kelvin. So you've heard of Kelvin temperature? This is the guy who decided we need absolute measures of temperature as opposed to relative. In Fahrenheit, it's relative to, 0, whatever that is. There's freezing anchors, there's all kinds of systems out there. But Kelvin said, we need something that's absolute. Why? And this is what he said: when you can measure what you're speaking about and express it in numbers, you know something about it. But when you cannot measure it, you cannot express it in numbers, your knowledge is of a meager and unsatisfactory kind. And what we're trying to do is provide those numbers so people can use them. That's what we're offering here. So with that, I'd like to thank you, and we've got a few minutes for questions. Anybody has any?
So you probably said it, but I was with your dashboard that you use with clinicians and so forth. I was curious about what is the basis for the probabilities and things that you computed there, as in how big is the database upon which it is based, et cetera.
Yeah.
And you may have said it and I just missed it, but.
So it's based upon our database. We've got 1,000, well, and what I was showing you today, we got 1,041 patients in there. So it's all relative to them.
Okay.
But we test them on multiple times.
Sure.
So we've got over 10,000 tests we've got with these people. And even this is an outdated database. We're up to about 2,400 people, I think it is, as of right now.
Okay.
That's January's database, and we're still we analyze it every 6 months.
Yeah.
The lies look very similar, so I don't want to read through all this stuff.
Yeah. Okay. Thank you.
Sure.
Was chronicity considered in doing some of these models and predictions?
Yeah, that's pain intensity.
Okay.
Yeah.
Versus looking at the length of the back pain, or is that kind of wrapped up in that pain intensity?
We do both. So
Okay.
there's several pain motion. We give them questionnaires. We give them iPads,
Mhm.
and they have all these questionnaires and just get all the information. It automatically goes in the cloud, so we have all that stuff immediately captured. I should also say a lot of physicians collect this data, but 95% of the ones who collect tell us they don't look at it.
Okay.
Yes.
I saw in your training video, you had specific movements the patients had to do. Like one of them was rotate your trunk without moving your hips. Are there any patients that aren't able to do that? And if they can't, how does it affect anything?
If they can't do it, they don't do it. So we tell them that. Our patient group were people who volunteered for the study. And these are we targeted people with chronic low back pain. So these aren't brand new back pain. It's not acute. acute is when it first happens. These are people who've had it for at least 3 months. All of them could do it. So we tell them, an IRB says you have to do it. If you can't do it, stop. But if we have 1 or 2 people who said that, everybody else does.
This falls into the causal pipeline domain more, but if I wanted to be part of the 20% that never gets back pain, you have like a thing that
I wish I knew. I went to a conference back in May, and there's a guy, Dr. Dvorak, has been doing spine research for like 50 years, and he's the consultant to the International Soccer League, whatever that organization is called, and he's on a campaign. He's the medical director for all of soccer in the world. And so he's on a campaign for prevention. If these guys are multi-million-dollar players, if they get hurt, they're toast, right? And they lose a lot of money. And so he's on this campaign to get them to do exercise and things like planks and things like that turn out to be great exercises. So it's much easier to control back problems if you prevent them as opposed to treating them with. We know that because he's shown that in his research over the years, is if you do these things, it works. If you don't, that's when back problems occur. It's really hard to get people back there. As a matter of fact, there was an article in one of the journals at the beginning of the year that showed the efficacy of 56 different treatments for back pain. And the highest efficacy out of all those? So efficacy is how effective is it? 12%. 12%. And so it shows that, let me say it bluntly, we suck at as a society at getting people better with back pain. We don't know what we're doing, and that's the motivation for all this, is to try and help. Yes.
Kind of a two-part question. So, as we're discussing, when people have heart disease or when people are diabetic, we know exactly what to do. We don't hear. From the time you began this work, how far down that road do you think we are now? And the second part of the question is, what are your views about the potential of AI being utilized to bridge the rest of that gap?
Yeah. Two very different questions. So let me go back to when I first started doing research in back pain, which is like 40 years ago. I used to give the analogy that, just like I said, we haven't progressed much in 40 years. I used to give the analogy is if full knowledge of back pain was a yardstick, we're probably at the 1-inch mark. Now we might be at the 2-inch. So, we're getting there. At least we're starting to look at the right thing. And there are lots of people who are looking at this kind of stuff too, not just us. And you're getting, this backpack group that I'm part of. There's a lot of really great work going on there. There's Anton Bowden at BYU, who's, hi Anton, hopefully he's listening.
He's on the Zoom.
Yeah. So he's one who's doing very similar work with different technology. We've got people who are looking at stool samples. We've got people looking at saliva. We've got people looking at blood. They're looking at other psychosocial dimensions, things like that. Got all that kind of stuff. So I've got a lot of hope, and especially when you put these technologies together, I think that's what we're learning here. Because when I was my PhD's in bioengineering, so when I first started, I thought bioengineering could explain everything, and it didn't take me long to figure out that people are really messy, really complicated, and I really have to start understanding all the anxiety, depression, sleep. So all that stuff we know has an influence. We just don't know how. So that brings me to your second question about AI and ML. That's how we're analyzing all this stuff. It's trying to throw it into the AI bucket and try and figure out if there are patterns. But if there are, you just can't take those and run with them. You got to figure out, is there a causal pathway that makes sense? Because AI can, and so we look at those things and we do, like I showed you a little bit of the modeling earlier, we do with personalized modeling. So if we find like lateral motions are indicative of what's happening with this phenotypic group, we'll go to the lab and we'll test people with that. Get their MRIs, get their CTs, wire them up with EMGs, model it, and see if there are more forces there, when they move laterally at different speeds and things like that. So we try and validate everything we do. Sure.
Thanks so much, Bill. Great talk. And thank you for pointing out for residents and others that if they don't do an exam and have them walk in the hallway and observe their gait, they fail. Thank you so much for that. Well, now listen, finally. Just kidding. I was in two-part question. One is, I noticed in that one table of the different three, there were, you had a table in 3 columns. The one metric which was the most strikingly different was interestingly high blood pressure, which I was like, I don't know if you have taken a dive into that one, because it's, I'm not sure what's driving that, but that's fascinating.
Yeah, I have hypotheses, we haven't tested it. But, one hypothesis might be they're more, they're heavier, more obese, high blood pressure is often associated with higher BMIs, things like that. We know they had a higher BMI in that same table, right? Other than that, I don't know, maybe we could talk about that sometime.
I appreciate it. I love theories anyway.
Yeah.
The other question I was going to ask though is, in chronic versus acute are 2 very different arenas with back pain. And in the acute pain, we see people who have significant, catastrophizing and all that sort of stuff going on. They move fairly well. It looked like, and I'm just checking to see if I understood this correctly, in your data, the chronic pain, they were pretty disparate. They really separated themselves out.
Yeah, so there was about 20% of the population of people who qualified for the study, passed the screening, had long-term back pain, things like that, who moved just normal. Yeah, but they had all these other things, like the one when I showed those 3 patients, the one guy moved just great, but he had all these psychological issues and things like that. So that's maybe where cognitive behavioral therapy or something like that might be that person's problem. I don't know. I'm not a clinician, but that's suggestive that something like that may be looked at by the clinician.
Phobia would make sense for certain aspects like spinal stenosis, those sorts of things,
Right.
some of the neuropathic pain. So I think some of that makes sense, but I just love the work because, the phenotypic issue is really important to hone treatment. So thank you very much for pointing all that out.
Well, thank you. Yeah, we're having a ball doing this too. It's like, it's just like research. Under every rock, there's a new story, right? And so we're trying to follow that. So. All right. Well, if there's nothing, are there any online questions?
There are not.
Okay. Well, thank you all very much.
Thank you very much.